Welcome to the AOT Pod, an all-new FRCS-themed podcast, tackling key themes, challenging topics, and insightful intellect within otolaryngology. Hosted by Livy Kenyon and myself, Kala Kumaresan, with the support from the ENT UK Foundation and AOT. Your guide to passing the ENT FRCS starts here as we take you around the country, speaking to some of the best and brightest minds our specialty has to offer. So without further ado, let's begin.
Today's theme is hyperparathyroidism, and I'm pleased and privileged to be joined by Mr Sid Nagala, who is a consultant head and neck, thyroid and parathyroid surgeon at the Royal Berkshire NHS Foundation Trust. Alongside his clinical interests, Mr Nagala is the ENT research lead at the Royal Berkshire Hospital and the current NIHR ENT lead for the South Central region. He actively engages in national NIHR trials such as HOT and RABBIT. He collaborates with the University of Reading with research interests including the use of generative artificial intelligence in healthcare, specifically in patients with thyroid nodules and cancer. Mr. Nagala has previously completed a translational PhD evaluating imaging biomarkers in thyroid tumours at the University of Cambridge. He has also served as the British Association of Endocrine and Thyroid Surgeons Executive Committee member as the education lead. He currently represents the same organization as the innovation lead. He is regularly invited to speak at national and international courses and conferences in relation to thyroid and parathyroid surgery. Welcome, Mr. Nagala.
Thank you, Carla. Thanks for the invite. It's just a real pleasure. Obviously, for AAT, I was AAT president in 2018 to 19, so it's always a really nice thing for me to do.
It's really nice to hear from you. So let's just jump right into it. When did you take your FRCS exam and what was it like? What was going on in your life at the time?
Yeah, that's a really good question. As you come into your exams towards the end of your training, it's pretty busy. So I did my exam actually probably the year before I was the AAT president. So I think it was 2017, 18. It's been probably nearly 10 years, 9 years now. But it just feels like yesterday. So it's quite memorable and quite a big part of your life really at the time. So I mean the exam, I was lucky enough to pass part one the first time round, but actually part two I failed the first time very narrowly, but probably in many ways it did me well, and I worked harder and learned a lot more and passed the second time around. And so yeah, I think I can certainly have to give tips on it was a while ago, nearly 10 years ago, but I don't think a huge amount has changed. But yeah.
Are there any tips that you would suggest?
Part two for setting the vibers, I would say practice, and do kind of the core topics, and really ask your consultants that you work with or any senior trainees who've done the exam to do lots of viber practice. I think that goes without saying.
Right. So today our theme for the podcast is hyperparathyroidism. So I'm going to come up with a case scenario that I've seen recently and we can discuss about that.
Sure.
So
yeah.
A 56-year-old lady was referred to you by your endocrinology colleague with persistently raised calcium and parathyroid hormone. How would you assess this patient?
I'm quite lucky. I work in a hospital where the endocrinologists do a lot of the workup when it comes to obviously the question being referred. They often refer to me and my colleagues for consideration of parathyroid surgery, and I think that's the key. Really, is they should only really be referred to you as a surgeon if they are a potential candidate for parathyroid surgery. I think a lot of patients with primary hyperparathyroidism or other parathyroid disease don't even get to see you because they're managed medically or conservatively. So that's probably the key from my point of view.
For the benefit of our listeners, I'm going to elaborate on the basics of hyperparathyroidism. As Mr. Nagala has described, most of the times when patients come to see the thyroid and parathyroid surgeon, the patients are already worked up and a preliminary diagnosis of their condition is already made. So in terms of hyperparathyroidism itself, it is the presence of raised calcium levels due to dysregulation of calcium hemostasis from excessive secretion of parathyroid hormone. It can be classified into primary hyperparathyroidism, secondary hyperparathyroidism, and tertiary hyperparathyroidism. For surgeons, primary hyperparathyroidism is what we most commonly manage. And most commonly, this is a single adenoma. In about 80 to 85% of patients, it is usually a single adenoma. The rest of the times, it can be a multi-gland hyperplasia, a double adenoma, or rarely a carcinoma. The classic symptoms that these patients present with are stones, bones, groans, and psychiatric overtones. As per traditional textbooks, I would also refer to the NICE guidelines and the recommendations set therein to understand the assessment by the primary care service and endocrinology team. Most of these patients are fairly asymptomatic, and otherwise may present with some symptoms. This can include a calcium over 2.6, nephrolithiasis, osteoporosis or fragility fractures, chronic non-descriptive fatigue, neurocognitive symptoms, or constipation or polyuria. Severe hypercalcemia can cause acute mental status changes, i.e., the psychiatric overtones. Following the diagnosis, it is important to do certain blood tests. The endocrinologists also assess for vitamin D, creatinine, EGFR, and also assess 24-hour urine calcium. They also tend to measure the calcium-creatinine ratio to rule out familial hypocalciuric hypercalcemia. It is really important to test for familial hypocalciuric hypercalcemia, as this patient group does not benefit from surgery. Mr. Nagala, following the tests, patients have a preliminary diagnosis and are referred to you. How would you further assess these patients in terms of imaging?
Yeah, sure. So again, units differ somewhat as to the imaging modalities that are used for primary hyperparathyroidism and hyperparathyroidism. We actually in Reading, our endocrinologists book the scans if they feel that they're surgical candidates, and we often see them in clinic with the scan. So we actually generally want the scans, otherwise it'd be repeated visits and, reduced efficiency. So the scans that we tend to do as first line is an ultrasound, and also it was previously a MIBI, but now it's a SPECT MIBI. Literature shows that MIBI can show up to around 60% of parathyroid glands. The ones that tend to be oxyphil rich or mitochondria rich in oxyphil cells, and the oxyphil dense adenomas are the ones that show up on MIBI. And then the SPECT maybe adds an extra dimension, and that actually increases the pickup rate more in the region of around 80%, or at least it should do. I'd say it's a little bit operator dependent, and we know radiologists can call things differently based on the imaging. So it's really important to look at the images yourself when you're assessing these patients for locating the parathyroid glands. A case in point, actually had a patient who ended up having a double adenoma just on Friday when we did an operation, although the reports had said it was concordant to one side only. But actually looking at the MIBI images and the SPECT MIBI images, it was relatively clear there was another adenoma on the other side, and actually with the benefits of intraoperative PTH levels, which we have, again, fortunate to have, I was able to remove the first side of the first adenoma, and then since the levels didn't drop, went to the other side where I thought there might be another adenoma. We found that, and then it did drop quite significantly after the removal of the second adenoma. So.
Right. When would you order a 4DCT?
Yeah, so again, in my practice, that's changed over the year in recent years. So previously, we used to do 4DCTs for patients who, say, maybe had a failed exploration. More and more units are using that as a primary modality now, and we tend to use it primarily because of possibly increased radiation exposure, although there's not a huge amount more, but I tend to use it in my practice is when the MIBI is negative, when the ultrasound is negative, and then I tend to do a 4DCT, and that actually does give a pickup rate of glands that have maybe been missed on ultrasound and MIBI. I find it quite useful actually in recent times.
Okay, and I understand some specialist and tertiary units also use colon PET.
Yes, yeah, colon PET again is another. You're right, it's only available in certain centres, in more kind of tertiary or quaternary level centres, and we don't have it here, but if we need that kind of scan, or patients who may need revision surgery, for example, our local unit would be Oxford, but again, everywhere's got different centres, more to their region. But colon PET tends to be done for patients who've had maybe failed parathyroid surgery and all the other imaging has not shown a target. So generally with revision parathyroid surgery, the general rule is you'd want to go in when you have a target. And I think if you don't have a target, it is very challenging and to go back in unless you're confident maybe the previous surgeon hasn't explored fully.
Mr. Nagala, intraoperatively, are there any other ways of localizing the parathyroid gland?
Yeah, so one of the big innovations in recent times in this space is fluorescence, which is applicable both for thyroid and parathyroid surgery. Possibly more in thyroid surgery because it is useful for locating parathyroid glands and preserving them. However, for parathyroid adenomas, it can also be useful because it does occasionally show enhancements. So there's two types of fluorescence that you can use. One is image-based fluorescence, which could be autofluorescence or ICG fluorescence, which is actually the current machine is a flow beam, and there are some other endoscopic machines as well, but the flow beam is the one that we use in Reading and can be helpful for sure. And then the other device is probe-based autofluorescence, which is essentially the PTI, which is a Medtronic-based machine, which is essentially a probe that can locate parathyroid tissue compared to thyroid tissue, which again is relatively new and only a few centres have got it, but it certainly is an adjunct. And I think both of these things will be helpful more and more in the future. And essentially they're adjuncts. Of course, you could do the surgery without them, but I think all very useful in getting really good outcomes, which is obviously the whole point of parathyroid surgery and any surgery.
Okay, that's interesting. So when we talk about indications for surgery, I understand most patients can be asymptomatic. And in these cases, it is important to understand that we would generally tend to look at operating for patients who have a serum calcium over 2.8. Is that correct?
Yeah, so I think it's supposed 2.8, 2.85. There's specific, as you mentioned earlier, the NICE guidelines in recent years have really helped and also maybe kind of slightly hindered in some people's views. And essentially, they are guidelines and not protocols. So roughly, if the calcium is over 2.8, 2.85, or they have end organ damage, so osteoporosis, kidney stones, or if they're young. But again, there are grey areas. Some patients have osteopenia, and then they have and symptoms are very difficult to pin down. Some of these neurocognitive symptoms you're describing, fatigue, those kind of things, or mental, or dysfunction cognitively. And is that because of due to the high calcium levels or parathyroid levels, or is it due to other things? There's lots of other causes of those types of symptoms. So it's can be a grey area. So I think often the important thing is to discuss with patients the pros and cons of potential surgery.
When you consent these patients for an operation, if the parathyroid gland that is causing these symptoms has been identified with imaging, I understand they would be consented for parathyroidectomy, which can be minimally invasive. However, if the scans are not conclusive, how would you consent these patients?
So if the scans aren't conclusive, the general teaching, and certainly I still do in my practice, if the ultrasound is negative, MIB is negative, 4D-CT is negative, I would just do a bilateral neck exploration as a primary treatment to visualize with the aim to visualizing all four glands, and hopefully by doing that you would identify an abnormal gland. Obviously, there's always a case that it's not there, or you have ectopic glands, and I tend to consent patients saying, if in this kind of scenario, to let them know there's probably a slightly higher risk of failure there if there's no obvious target, and you're doing a bilateral exploration, because there may be an ectopic gland, so elsewhere in the body, so in the mediastinum or higher up in the neck. And there are some units advocating potentially doing a choline PET even before doing a bilateral exploration, but that's really kind of up for debate, and there's different practices going on. But it's all interesting. Things are advancing all the time in this space when it comes to localized adenomas.
I understand sometimes the afflicting gland can be within the thyroid tissue, and in some cases, surgeons would do hemithyroidectomy along with the procedure. How often would you consider this, either intraoperatively, or is this something that you would discuss with the patient preoperatively?
Yeah, I think intrathyroid adenomas are interesting. I think it partly depends on how confident our radiologists are in identifying intrathyroid adenoma. Not always easy. For example, there may be a thyroid nodule, and you may think it's actually parathyroid nodule. You can do an FNA of those nodules and do a parathyroid hormone washout, which can be helpful.
It's very interesting. So I understand in your practice, you have the option of intraoperative PTH monitoring.
Yeah.
However, in many smaller units, there is no access to this type of monitoring at this stage.
Sure.
So how did you do things before you had the option of this monitoring, and how do they do these things in smaller units?
Yeah, that's a good question. So you can always check with your labs and check if you can do intraoperative monitoring even through your lab. It takes longer, and we did have that for a while in Reading before we moved to the point of care testing with NBCL. So, but before that, obviously what people tended to do, and people do, is if there's concordant imaging, but two modalities pointing towards one gland, offer a targeted parathyroidectomy, which is feasible. I mean, some places or some surgeons use frozen section, which may confirm a parathyroid, but it doesn't necessarily tell you you've cured the patient, because there may be another gland or multi-gland disease. So what I tended to do was do a targeted parathyroidectomy, but also look for a normal parathyroid gland on the same side. So because you don't really want to go back in on the same side. If for whatever reason you've not cured the patient, you've still got the other side, you can always go back in at that point. So otherwise it would be very much a 4-gland exploration, and you want to look at all 4 glands.
And for the sake of our listeners, I would like to add that we generally follow the Miami criteria. There are other criteria available as well. So some hospitals may vary in the way they measure the post-op parathyroid hormone drop. But generally, we check the PTH pre-excision, and at 10 minutes, a drop of over 50% from the baseline suggests cure. So, other than primary hyperparathyroidism, I would like to ask you about secondary hyperparathyroidism.
Yeah, sure. I think secondary hyperparathyroidism could be either low vitamin D or chronic kidney disease. But we tend to do surgery for renal patients in a tertiary setting when they've had chronic kidney disease for many years and are all almost basically dialysis patients. So those kind of patients tend to have overactive parathyroid glands and have raised parathyroid and calcium levels, whereas in secondary hyperparathyroidism, you have raised parathyroid levels, but tend to be more like normal calcium. So we don't necessarily operate on those patients, but it's the renal patients. And we again, in Reading, we do operate on patients with renal hyperparathyroidism. And often the reason for doing that is so that the parathyroid disease can be treated so that they can go onto the transplant list, because often getting a transplant for the kidney, major blocker is if they've got really high levels of parathyroid levels which need treating, and in that setting you've got 3 or 4, usually 4 glands that are overactive. So you want, the kind of general kind of aim is a 3.5 gland excision parathyroidectomy. Some units advocate 4 gland parathyroidectomy as well, and it all very much depends on your renal team and your renal setup for that.
Right. And the other indication can also unfortunately be in long-standing patients with secondary hyperparathyroidism, post-renal transplantation as well. Is that correct?
Yeah.
They can also develop
patients with post-renal transplant, and they've almost had a secondary, almost like a primary kind of picture. So there is a bit of a grey area, and actually, which is important, because it's not when it comes to real world practice, it's not like the textbook. There's lots of grey areas, and actually, as a result, certainly in Reading, and I think a lot of units who have a relatively high volume practice in this area have MDTs. So, we really value our endocrinology MDT, which we've also added the renal physicians to come on. So we have a monthly MDT with endocrinologists and renal physicians where we discuss the more complex or challenging parathyroid patients, both primary and tertiary, and also, difficult thyrotoxic patients as well. So I find that really helpful, and you learn a lot, and actually I think it's really good for patient.
Are there any specific complications that can happen from parathyroidectomy?
Yeah, so when we consent patients with parathyroidectomy, when it comes to complications, it's the general complications, so bleeding, infection, excessive scarring. The big ones are probably failing to cure. So I think I really want to quote your own numbers, and depending on if they're targeted and exploration. The other ones, you can actually get hypocalcemia, so you can go the other way, especially if you're doing a 4-gland exploration. And the other one is if they've got hungry bone syndrome, the calcium just plummets, and then as a result, the calcium just goes straight into the bones. The bones have been depleted for calcium for so long, and then as a result, your calcium levels can go really low. So it's something to worth. It's pretty common in older people, that phenomenon. So it's worth keeping an eye on that. And the other one is neuropraxia, nerve injury. So I tend to use nerve monitor for all cases.
Okay. Other than surgical treatment for parathyroid adenomas hyperplasia, is there anything you can tell us about parathyroid carcinoma that we should remember?
A few times I've seen parathyroid carcinoma. Tends to be patients who get really high levels of calcium. They almost come in as an emergency where they're in a hypercalcemic crisis. Often, not always, but that's them. The other thing is, on imaging, there may be some features that are concerning. So very irregular margins on the ultrasound of any parathyroid tissue, or on the imaging, SPECT imaging. So those are the kind of things. And the other, obviously, not just carcinomas, the atypical adenomas as well, which there's a spectrum. So some I mean, sometimes you do an operation, you think, oh, this is really stuck down, or I think this could be cancer, but actually it ends up being an atypical adenoma. So yeah. And then the other aspect with the few carcinomas I've dealt with is if you're suspecting that type of situation, then you always consent for a hemi, because often you need to do a hemithyroidectomy as a not en bloc resection with the parathyroid tumour.
And I understand they're quite rare, less than 1%.
If you do quite a lot of them, you will see them, but yeah, they are rare. Yeah.
So, Mr. Nagala, in patients who are not fit to have surgery, what options do they have?
So I think for patients who have not super high levels of calcium and relatively asymptomatic, and again, certainly one option is just to monitor for doing DEXA scans, and you can actually treat osteoporosis medically, for example. I think the thing is with the patients with the high calcium levels, you can have medications which are now more available. So cinacalcet is a big one. And we do see the use of cinacalcet more and more now, often actually as more of a bridging towards surgery, because patients who have corrected calcium over 3 often go on cinacalcet until they get surgery. But in some people and some elderly people, for example, who aren't fit for general anaesthetic, they can just go on cinacalcet as long as they they don't get side effects. And okay, and some people don't tolerate cinacalcet. That is an issue. Nausea, and it's not necessarily a primary treatment or recommended treatment, but it is an option.
In case of patients who have acutely high hypercalcemia and are acutely unwell and require admission, I understand the primary line of treatment is to hydrate these patients and consider giving them some steroids.
Yeah, so often our endocrinologists see these patients, they come in with a hypercalcemic crisis, and then they work them up. And I've certainly, again, in our practice, we've done a number of patients as emergency parathyroidectomies because they couldn't get them out of the hospital, couldn't get the calcium under 3. So as an inpatient, they get cinacalcet, a lot of intravenous fluids to try and get the calcium down. But sometimes it's very difficult to control that calcium to get it down. So there are kind of other options, but essentially the bottom line is if there's a big adenoma, for example, we need to get the calcium down low enough so that the anaesthetists are happy, and so you can go ahead and do surgery and removing the offending gland or glands. Another treatment option for patients who are medically unfit for primary hyperparathyroidism and has a single adenoma, some places around the world have started to do this, is radiofrequency ablation of the adenoma, which you can do obviously while the patient's awake, not having a general anaesthetic. And so this is getting more popular, especially in the Far East. And there are certainly cases that I know that people have started doing around the world, not necessarily in this country, but that is something to look out for the future.
Right. That's very interesting. So, Mr. Nagala, is there anything else that you would like to add?
Yeah, I just wanted to add just a few points, really, just be really useful for your listeners. First thing is really about BAETS and the organisation, the British Association of Endocrine and Thyroid Surgeons. As an organisation, I think as a trainee, you could really benefit from joining it, and they've got the Cocker Club and trainee reps as well. And there's a BAETS registry that we all, as parathyroid surgeons and thyroid surgeons, should really add to, and to record their numbers and their data. So that's one thing. And the second thing is there are actually post-CCC fellowships in thyroid and parathyroid surgery, and we have one in Reading, which is an annual fellowship, and there's some other ones around the country, including Stevenage. So that's something, again, for your listeners and trainees who are interested in thyroid and parathyroid surgery, are good things to potentially think about. The other really good thing about the BAETS organisation is the education aspect. So when I was education lead, I organised multiple webinars, which are actually all on the BAETS website. And also we organised an annual masterclass, which is thyroid related, but we also do parathyroid masterclass every 2 years, which is run in March, which you can actually register online, and this is run by the Royal College of Surgeons of Edinburgh together with BAETS. I've been lucky to be a section co-editor for the endocrine section for the next Scott Brown, which is going to come out any week now actually, and that's a really great reference text for parathyroid surgery as well as thyroid surgery.
Great, thank you.
And then finally, I just wanted to really mention about approaches for parathyroid surgery. So obviously the classical and traditional method is open approach for a bilateral neck aspiration and cervical incision. There has been over the years a vogue towards minimally invasive approaches. So you can have small scars, you can have something called MyVAT, lots of different ways that people have done the approach to it. And there's pros and cons for both. I mean, I personally feel a symmetrical central incision is quite cosmetically good if you can do an open approach. Equally, some surgeons are starting to do facelift approaches to hide a scar, and the other big approach that's really popularized in recent years is a transoral endoscopic approach, which you can do thyroid and parathyroid surgery, which doesn't leave you with a scar at all. So we in Reading with my colleague Mr Morthy were the first in the UK to do that. And we've done parathyroid operations transorally and doing it scarlessly. There are indications for transoral endoscopic approach parathyroidectomy. These include the patient needs to have good dentition, relatively slim neck, and relatively fit and well. Ideally, the adenoma should be inferiorly located and slightly separate from the thyroid gland. However, as you get more experience, surgeons can target superior glands as well, which is a little bit more technically challenging. But in Reading, we do take national referrals for patients who may want to have scarless parathyroid surgery.
Okay, thank you so much. So, Mr. Nagala, what is the future of parathyroid surgery and where is innovation currently?
Sure. Well, I think as the BAETS innovation lead, I'm in quite a good position to answer that. There's loads going on in this space of cutting edge research and innovation, and I think in 10 to 20 years, how we do parathyroid surgery and thyroid surgery is going to be really different. And I think a lot of the things are based on things like obviously artificial intelligence that we know about. That's really come in. More remote access types of operations, including robotics, that improves. The big society actually it's a relatively new society. It's been running for nearly a decade, but it's called the International Society of Innovative Technologies in Endocrine Surgery. It's a society where they have an annual conference that they locate in different parts of the world. The last year was in Washington, the year before in Barcelona, and actually next year we're hosting it in the UK in Sheffield. So my colleague and ex-boss, actually, Professor Balasubramanian in Sheffield, is on the council of this organisation, and he's hosting the conference between 17th to the 19th of March, and myself and him are organising the conference. So I think that's going to showcase, it's the 3-day conference, showcase the latest technologies, cutting edge technologies in endocrine surgery, which is obviously thyroid and parathyroid surgery. So I think if you want to know more about what's the latest in innovations, that's a conference to go to.
Okay, great. Thank you. To summarize the key points, the diagnosis is biochemical. It's not image-based, and imaging should be reserved for patients who are surgical candidates going down the surgical treatment line. Normal PTH with hypocalcemia is still abnormal and still requires investigation. Always rule out familial hypocalciuric hypercalcemia before surgery, as these patients do not benefit from operative management. Intraoperative PTH drop more than 50% predicts cure as per Miami criteria, and most cases of hyperparathyroidism are due to single adenomas. And that's it for this episode.
Thank you for listening, and we hope you enjoyed this episode of the AOT Pod. Be sure to check out our other topics and give us a like and subscribe to get notified when new episodes become available. For more educational resources, visit the AOT website, aotent.org, and our YouTube channel. And make sure you attend our national conference, where there are prizes for oral and poster presentations up for grabs. See you next time.